Thank you very much, Bertrand, and thank you, Julio, and everyone. It's a pleasure to be here, and it's really wonderful to see the vibrant discussion. I have to make a confession first. I developed this wonderful talk that had the title of When to Start Treatment, a Clinician's Perspective. Then last night, as I was checking to see when we're starting today's conference in the morning, I realized that was not the title I was assigned. So this is a fresh, new presentation. It's not a clinician's perspective, it's an investigator's perspective. So let's keep going. So I'm going to talk about, focus my conversation today briefly about the workshop tagline. And the tagline is From Evidence to Action. And the question I have here as an investigator is, do we have all the evidence we need? Are we into the space of just action, or do we still need evidence? So is there a need for any new evidence to inform what type of action? And what evidence do we need in terms of the efficacy of the interventions, of their effectiveness, or even what implementation effectiveness evidence we need? And then the second dimension is there a need for evidence to be garnered from our actions? So there are two spaces. One is the space of evidence, and the other one is action. I believe that there's a need to continue to derive evidence within both of those domains. So I sort of use the same framework that I used at CROI, which is first of all talk about the evidence in terms of the science. What do the guidelines say about early ART initiation for HIV-infected individuals? And these are the DHHS guidelines just published in 2012. And I'm going to focus on the earlier CD4 cell counts, the greater than 500. Well, you see that the recommendation is a B3, and a B3 means the moderate strength of the recommendation, and 3 means it's based on expert opinion. For 350 to 500, it's an A2, meaning it's a strong recommendation with non-randomized studies or observational studies. Obviously, for less than 350, it's A1, meaning the strong recommendations and the evidences of our clinical trials. So let's focus on clearly where the questions are and where we need further evidence and investigation. We know that for the lower CD4 cell count strata, as you can see here in this figure, the risk of AIDS or death or non-AIDS events is quite high. And there's evidence that in this strata, ARTs do have a salutary effect in terms of prevention of such events. We also know that the risk of HIV transmission by CD4 cell count is higher in individuals with lower CD4 cell count. Again, if you look at less than 350 and you look at the rates of HIV incidence, this is in discordant couples, not on ART, you'll see that these groups have higher HIV transmission rates, meaning that for the lower CD4 cell count, we have strong evidence in terms of the effectiveness or the efficacy of ART for the individual and the potential effectiveness or efficacy, of course, in trying to bring down these high rates of transmission. When we look at the higher CD4 cell count, where we have the recommendations that are in the domain of B2 or B3, I think that's where there's more ambiguity, and that's where we need more evidence. Of course, in these strata, the risk of AIDS or death or severe non-AIDS events is much lower than in the lower CD4 cell counts. So what is the evidence for benefit or risk for HIV-infected patients with CD4 greater than 350, and what kinds of evidence do we need as investigators? Clearly, pathogenesis studies have demonstrated the effect of ART on the effect of HIV on organ systems and on immune depletion. There have been several observational studies of ART use in developed countries, but there's no evidence from any observational studies of ART use for resource-limited countries. And the evidence from HPTN 052 is limited to individuals of CD4 between 350 and 550. So here are the observational study. There's one study, NA Accord, which shows that in patients with higher CD4 count, there was a preventive effect of ART on death. But there have been two other observational studies that did not replicate this protective effect of earlier initiation of ART. And all of these studies, observational studies, was in resource-rich countries. There are no data from resource-limited countries. Now, in terms of 052, which provides the best evidence, what else do we need beyond 052? Keep an eye on the clinical primary endpoint for 052, which included WHO stage 4, pulmonary TB, severe bacterial infections, or death. And as you know, there was a significantly improved outcome in terms of the immediate ART arm versus the deferred ART arm in terms of this composite endpoint. But when you dig in deeper, you'll see that there was no difference in terms of death. And the main significance was really due to extrapulmonary TB events, where there were 3 in the immediate arm and 17 in the deferred arm. So what other evidence do we need beyond 052 for people who have HIV themselves? Keep in mind the comparator arms in 052 were not above 500, and the deferred arm was quite a lot lower than the current threshold. You look at the median CD4 cell count for people who was approximately 450 at baseline, and the difference in composite clinical endpoint was really focused on extrapulmonary TB. Most of these diagnoses were based on a presumptive diagnosis in an unblinded study, and there was also no difference noted in pulmonary TB, severe bacterial infections, WHO stage 4, or death. So there's clearly is room for further evidence to increase our confidence in the individual benefit of ART for patients with higher CD4. There's no question that we have pathogenesis studies, but that's quite different from saying that an intervention like ART will have an impact in terms of outcomes. In terms of the risk of HIV transmission, obviously the evidence we need is on populations, meaning to go beyond in all the CD4 cell count and see what would be the impact in terms of, at a population level, the efficacy at a population level of use of ART for prevention. The good news is, as Carl mentioned yesterday, there's a START study that's going to be looking at if early versus deferred ART in patients starting with CD4 greater than 500 with these clinical endpoints. And the other good news is that there also are the planned and ongoing treatment as prevention combination studies, which are going to answer the efficacy question in terms of at a population level and help us determine what worked and why it worked. I'm concerned also, wearing my investigator's hat, that most of the evidence we have on key populations, we heard a lot of data today based on modeling in sex workers or injection drug users or prisons or MSM, but we really have very little efficacy data on ART as prevention in these populations. We simply only have modeling, promising modeling results. So let's move on quickly to what I call the art of ART for prevention. And this is based really on my experience where ICAP works in New York as well as in Sub-Saharan Africa and in Central Asia. And this figure here, which I'm glad to see has been used a lot in this meeting, is the care continuum. And one message I want to just leave with you is that I believe that we should be saying that ART as, not only ART as prevention, but I think we should use the term that ART for prevention is really a combination intervention. It's not just ART, it's a combination which includes the testing, the engaging in retention, as well as adherence and maintaining viral suppression. So it is, by itself, is a combination intervention. So what about the foundation, which is testing? We heard some interesting data on 043, but I think, again, in terms of wearing my investigator's hat and implementer's hat, there's a lot more work that needs to be done to identify optimal methods for expanding HIV testing and improving the yield of HIV testing efforts in terms of identifying people who are HIV positive. These data you saw, I think, earlier of the community-based VCT versus the clinic-based VCT in Tanzania, Zimbabwe, and Thailand. And you can see in 3 years, the rates of testing were not really that high. There also are other data that looked at home-based testing, VCT versus provider-initiated testing, and testing in TB clinics. And I think there are interesting things to note from this study. One is that if you looked at provider-initiated counseling and testing, you certainly identify people with late disease, but those are the most urgent to get on treatment, whether for their own good or for prevention. For home-based care, the experience is quite home-based testing is quite limited when compared to the numbers in this one study that received testing in VCT or provider-initiated testing. But nonetheless, it appears that the mean CD4 cell count was higher than in the other settings. But this needs to be replicated and to also look at the impact on linkage from these settings to care and treatment. In terms of other areas where we need a lot of research is in terms of trying to improve entry into care. And these are data from the US by Kate Pujas from CDC that look at the median CD4 at entry into care. And of course, from 2000 to 2009, the darkest black here are less than 200. And you can see there hasn't been much shifting in terms of actually trying to get people to link into care earlier. So again, we have a long way to go. The factors associated with late diagnosis include not being MSM, older age, and not white race ethnicity. So we have a lot of work to do to try to do some research to try to really figure out how we can get people within the groups they're getting late testing to be identified earlier and linked earlier. In the NA Accord study, which is much larger, of 44,000 individuals from 1997 to 2007, you can see here that the proportion with greater than 350 at the time of presentation in HIV care increased from 38% in 1997 to 46% in 2007. But nonetheless, the median CD4 still remains less than 350, 317. So we need to identify interventions. We need to do a lot more research to know what to do about this thorny problem. Initiation in San Francisco, you heard about that earlier, and I think the message from San Francisco, although they've made this is data before they expanded treatment before 2010, and they have made a big dent in terms of that 48% of people in 2004 were initiating at greater than 350, and now it's 92%. But nonetheless, we're facing the same issues again, which is again, white patients, MSMs, non-poor, those diagnosed by a private provider were all more likely to initiate earlier. So again, it demonstrates the enormity of research questions we still have at hand to overcome these huge disparities. I'll quickly move on other issues. I'm very happy about the counseling guidelines, but nonetheless, this is another area where we also need a lot of evidence. There are lots of potential benefits to couples testing, and this is directly from the guidelines that were just released by Gottfried and WHO. But nonetheless, if you look at the recommendations, all of the recommendations are strong recommendations, with most of them with low quality of evidence, again demonstrating that we need to be testing each of these elements and trying to really provide the evidence so we can garner the benefits, potential benefits of couples testing. So I go back to the continuum of care and finish off by talking about, when we talk about the continuum of care, we're often focusing just on the patients. And I think there's almost a need to think of another dimension. That's the dimension of the providers and the system, the health system and the providers, and the importance of the health system and providers in terms of informing our research to optimize treatment for prevention. And there's a poster outside that I'll point to. I won't go through the results here of HPTN 065, where we did a provider survey of the attitudes of providers regarding early initiation of antiretroviral therapy. And I'll let you go and look at the poster, but I think the message is that we need to provide the providers with the evidence, but more importantly, we need to convince the providers to follow the evidence. So there's a lot of data here, but again, I don't have time. But I just want to highlight to you, for example, this question: how often do you ask about sexual partners' HIV status? And always was 37%, often it's 40%, but there are a lot of people not even asking that basic question, demonstrating again that we need to do a lot of work in terms of generating evidence for the providers and their own behaviors. Now, I'll end by talking about some of the other evidence that we need, and that's in the arena of implementation science. That's the learning by doing, or in a way, learning from doing. And there's several RFAs, as Carl mentioned yesterday, which is very exciting for implementation science from several institutes at the NIH. I think there's also a need for strengthening the monitoring and evaluation efforts in current programs so that these can provide the evidence to inform the action, almost in a cyclical kind of a iterative manner. There's a need to expand the efforts for collection of new types of data, and we talked about some of the costing data, but I also think some of these data about provider behaviors are very important as well in informing our actions. I think it's also important to expand the current indicators and move them to a focus on outcomes rather than a focus on processes. Now the indicators really want to measure how many tests have been done. That's well and good, but that's not good enough anymore because we have more important questions. How many tests did you do? How many people did you test? How many were positive? How many were linked? How many initiated ART? And so forth, and so on and so forth. And at the end, I'll leave you with one thought, which is, what if we followed kind of the all or none principle? And the all or none principle really means that as you're looking at the performance of a program or the performance of a clinic, you don't just measure the processes in this box, in this box, in this box, in this box, but the clinic or the program has to perform well on all these parameters in order to get a good grade or in order to be judged as a good program. So it's all or none kind of an assessment of the quality of the performance of the program. So that's it, and thank you very much for your attention.